Diabetes insipidus. Diabetes insipidus can be defined as the excretion of excessive or copious volumes of urine, traditionally greater than 3 L per 24 hours. Etiology and pathophysiology. Classically, 3 types of diabetes insipidus are recognized. 1. Hypothalamic, cranial, diabetes insipidus, in which there is an absolute deficiency of antidiuretic hormone, ADH, also called vasopressin. 2. Nephrogenic diabetes insipidus, which is caused by resistance to the action of ADH in the collecting ducts. 3. Dipsogenic diabetes insipidus, due to excessive inappropriate fluid intake, i.e. primary polydipsia. Dipsogenic diabetes insipidus is sometimes referred to as psychogenic diabetes insipidus, although this term is not appropriate in all cases and is therefore best avoided. Causes of diabetes insipidus. Hypothalamic diabetes insipidus. Primary. Idiopathic. Genetic, AD, AR, DIDMO-AD. Developmental, Lorenz-Moon-Beadle syndrome, septo-optic dysplasia. Secondary. Trauma, post-surgery, TSS, TCS, head injury. Tumor, craniopharyngioma, metastasis, especially breast, lung, germinoma. Very rarely pituitary macroadenoma. Inflammatory, granulomas, e.g. sarcoidosis, TB, histiocytosis, meningitis, encephalitis, autoimmune. Vascular, aneurysm, infarction, Sheehan's syndrome. Nephrogenic diabetes insipidus. Primary. Idiopathic. Genetic, XR, AR, AD. Secondary. Chronic renal disease, obstructive uropathy, tubulointerstitial disease. Metabolic disease, hypercalcemia, hypokaliemia. Osmotic diuretics, glucose, mannitol. Drug-induced, lithium, dimethylcycline. Systemic disorders, amyloidosis. Pregnancy. Dipsogenic diabetes insipidus. Habitual or compulsive water drinking. Occasionally associated with structural or organic hypothalamic disease, sarcoid, tumors involving the hypothalamus. Pituitary adenomas are very rarely associated with diabetes insipidus prior to surgical intervention. Hence, it is important to keep in mind the other conditions listed in Table 21 when faced with a patient who presents with a pituitary mass and diabetes insipidus. Epidemiology varies according to the underlying cause. Clinical presentation. Polyuria and polydipsia are the most common presenting symptoms. Nocturia on several occasions is typical. Indeed, if the patient is able to sleep solidly for 8 hours without needing to get up to the toilet, then it is unlikely that he or she has hypothalamic or nephrogenic diabetes insipidus. Symptoms of anterior pituitary dysfunction and the underlying disorder may also be present. Physical signs. Reduced visual acuity, and visual field defects due to chiasmal compression, together with papilloedema or optic atrophy, reflecting raised intracranial pressure, may be evident in cases of hypothalamic diabetes insipidus. Examine carefully for evidence of pituitary insufficiency. Other clinical signs will be determined by the underlying disorder. Investigation. Confirming the diagnosis of diabetes insipidus. Having established that the patient is polyuric, an assessment of renal concentrating ability should be undertaken. Plasma and urine osmolality. Measurement of paired early morning plasma and urine osmolality, together with urea and electrolytes, following abstention from / limitation of fluid intake overnight may help to exclude cases in which the index of clinical suspicion is low. The finding of a concentrated early morning urine sample, greater than 750 mmol/kg, together with normal plasma osmolality and electrolytes effectively excludes diabetes insipidus. Note, however, that given the unsupervised nature of this test, it should not be used in cases where genuine diabetes insipidus is suspected. Water deprivation test. For those in whom the overnight test fails to resolve the issue, or in cases with a higher index of suspicion, a formal water deprivation test can be performed, with subsequent assessment of renal concentrating ability in response to exogenous vasopressin. Hypertonic saline infusion test. Occasionally, difficulties arise in establishing the diagnosis with fluid deprivation. Moreover, milder forms of hypothalamic, nephrogenic and dipsogenic diabetes insipidus cannot always be differentiated with this type of test. In these circumstances, direct measurement of plasma ADH, AVP, concentration, together with plasma and urine osmolalities, during graded osmotic stimulation, by infusion of hypertonic saline, can accurately diagnose diabetes insipidus and differentiate the various causes. This investigation should only be performed in centers with experience of the test, and must not be undertaken in subjects with cardiac, renal, or hepatic impairment, who are likely to become significantly salt overloaded. Assessment of cause and associated complications in hypothalamic diabetes insipidus. Assessment of hypothalamic pituitary function. Evidence of anterior pituitary dysfunction must be sought in all cases of hypothalamic diabetes insipidus. NB. Remember that cortisol has a permissive effect on free water excretion. Accordingly, diabetes insipidus may be masked in states of cortisol deficiency and only become evident once glucocorticoid replacement has been commenced. MRI, or CT, scan of the pituitary fossa and hypothalamus. Mandatory in any patient found to have hypothalamic diabetes insipidus. The high signal normally seen at the site of the posterior pituitary gland is likely to be absent even in the absence of a mass lesion. Ophthalmological review. To provide a baseline for monitoring the effects of treatment. Treatment. Wherever possible, treatment should be directed at the underlying disorder. Hypothalamic, cranial, diabetes insipidus. Desmopressin, DDAVP, a synthetic long-acting vasopressin analog, is the treatment of choice for patients with hypothalamic diabetes insipidus. It can be administered via several routes: subcutaneously, intramuscularly, intravenously, intranasally, or orally. Patients should be treated with the lowest dose necessary to control their polyuria/nocturia and advised of the potential symptoms of over-replacement, especially if they have pre-existing cardiac or renal impairment. Daily weight measurement may help to alert the patient to cumulative overtreatment. In these circumstances, adjustment to the dose or regimen and omission of desmopressin for a short period at regular intervals, perhaps once weekly, to allow breakthrough polyuria, usually helps to prevent fluid overload. It is important to monitor plasma electrolytes at regular intervals after commencing treatment and following any dose adjustments. Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus due to an acquired metabolic problem is best managed by addressing the underlying cause and maintaining adequate hydration while function recovers. For those patients with congenital nephrogenic diabetes insipidus or an acquired irreversible defect, various additional measures can be tried, including high-dose desmopressin in cases of partial nephrogenic diabetes insipidus, thiazide diuretics/amiloride, NSAIDs, or dietary salt restriction. Dipsogenic diabetes insipidus. This is often an extremely challenging condition to manage, especially if the cause is not acknowledged by the patient. Reduction in fluid intake is the only rational treatment. Individuals with persistent dipsogenic diabetes insipidus are at significant risk of hypoatriemia if given desmopressin. Prognosis. Prognosis is largely dependent on the underlying disorder.